Thank you for joining us on our podcast on Labor Day with Francesca, Alex, and Vanessa. Today I'm joined by Tanya, who's a perinatal nurse, doula, and birthing coach, to talk about labor and delivery and about the different cases that can present themselves when you go through labor. So hi, Tanya. Thank you for joining us.
Thanks for having me.
So labor, I think I just want to preemptively say, when I first became pregnant, for the first time, labor was like the only thing I thought about. It was the scariest. It's going to be super scary. It's going to be super painful. And I think as first-time moms, that's what a lot of women focus on.
Yes.
When there's so much to focus on before that. Yeah. But I think that's really kind of the scariest part. Like, my vagina is going to rip open. It's going to hurt. They're going to need to stitch it. So I think labor is a very big topic. So let's talk about, we can start by talking about, I guess, Francesca, who had kind of the most traumatizing birthing experience. It was during COVID, so I mean, no choice, right?
It's interesting that you're even saying traumatizing, right? Yeah. Because when Francesca's describing her own experience, she actually never used that word. No. Right? Like, she was just kind of recounting it, like, as a matter of fact situation. Yeah. And everybody else, right, particularly Alex, was looking at her like, this is what happened. And she was perceiving her experience as traumatic. Well, right?
I guess had because she didn't know, anything. Different. She had nothing to compare it to. But now that we've had multiple children, all of us, we're listening to this story and just like, if I didn't have my husband next to me for my first time, I don't know what I would have done. But you have no choice.
It just goes to show, like, with everything else, pregnancy and motherhood and perinatal related, right? Everybody experiences things differently and everybody has their own perspective, and no two people deal with any scenario exactly the same way, right?
So let's just talk about labor in general. For me, my water broke, which I now know is very rare, if I'm not mistaken. Like, it's not a very common situation to have your water break.
About 10% of people will break, their water will break before naturally they experience any regular contractions.
So that's what happened to me. So I'm kind of happy that happened, I guess. I don't know. Because it kind of was my cue to say, let's go to the hospital, you know?
It's a bit more unmistakable, that's for sure.
Right. So Vanessa, on the other hand, stayed home until a little bit too long, I think. I don't know.
What's too long?
I don't know exactly. So let's talk about, your, I guess, 39 weeks or whatever weeks you are. You're kind of ready to go. You're at the term. Thank you.
So term. So any point past 37 weeks is when you can expect at some point to either go into labor, meaning have contractions that begin, or your water breaks.
Okay, so those are the two scenarios, either your water breaks or contractions start.
The most common, right? And the third scenario, which is a little bit different, would be if at some point you require a medical induction of your labor.
Correct.
And for the most part, for most first-time moms, unless they have some kind of medical condition, the most common reason is to go past your due date by a significant period, like 7 to 10 days past your due date.
Right. Like my Maddie came out almost at like 42 or
but
41.
But if we're not talking about the induction scenario for a medical reason or for passing your due date, then yes, the two scenarios would be either your water breaks or contractions begin, and at some point in that process, your water will break.
So my water broke, and it was just, and it's not like in the movies. I just want to kind of confirm that. It's really, it was just like a little trickle down of water that was going down my leg, and I thought it was pee for like 3 seconds. But then I reminded myself that I don't pee on myself usually. So I did, I connected the dots, and then we called the hospital first to make sure that it was time to come, and they said, yes, you should come in. But let's talk about contractions, because I've never, and then the second time I was induced. So I've never experienced, how much do they have to hurt? How far along do they have to be? Because quite frankly, had I experienced that, I don't know, like, I still don't remember what the rule is, like the 5-5-5 or whatever it is. So, I mean, and I think when we talked about it, I don't think anybody really remembered. Yeah. So what is the contraction kind of rule? When should you go to the hospital?
Yeah. It's confusing and people don't remember, and it's not something that's discussed, I think, enough in prenatal appointments, right? Our doctors have so few minutes to spend with us. But this is actually really crucial information, because if we, don't show up at the hospital at, an optimal or an ideal time, it can actually have consequences. So being admitted to the hospital early in our labor, like really early, before you have regular painful contractions that have changed your cervix, what tends to happen is you can be admitted to the hospital, and then at some point, you require more medical interventions to get your labor to progress for a million different reasons. And that's actually shown to not be optimal in terms of outcomes for moms and for babies. So I really hope that people pay attention to this. It obviously, I'm going to preface this with it depends on your situation, right? So I'm going to be talking about the general guidelines, but you always have to check with your provider about your own pregnancy. I'm talking about really low risk pregnancies, first time moms where there's not really any complications in general. So when we're talking about your labor beginning at home or at work or wherever it is that you are, for the most part, contractions will start slowly and build up over time. So at the beginning of labor, for most people, it feels like period-like cramping or menstrual-like cramping, and will just progressively become more and more intense in terms of the sensations, the feeling of squeezing in your abdomen. When you touch your tummy and your uterus feels hard, it will feel harder and harder when you touch it. You will obviously be more and more uncomfortable with your pain levels. And your contractions will eventually get a little bit longer, meaning from the beginning of the squeezing and the cramping in your uterus to the end, will become longer and longer. True active labor contractions tend to be somewhere between 60 and 90 seconds. And then your contractions will also get closer together, right? So contractions are like waves. Your uterus begins contracting, cramps, peaks at this quite uncomfortable level, and eventually the uterus releases, and then you have breaks between your contractions. This is for moms who haven't gone through this yet. And eventually those break periods between your contractions will get shorter. So when we talk to healthcare providers, when they're explaining to you when you should go to the hospital, for the most part, you'll hear about the 5-1-1 rule. Okay. And what that means is that your contractions are 5 minutes apart from each other. So that actually doesn't even mean the break in between. It means from the start of one contraction to the start of the next contraction, that period of time is 5 minutes or less regularly. So that's the 5 of the 5-1-1. The second number, which is the first one, means 1 minute long. So the contraction in and of itself, from the beginning to the end of the one contraction, is 60 seconds, so 1 minute or longer. And the last one of the equation is that this whole process of having contractions every 5 minutes, that last 1 minute each, has been occurring for at least 1 hour. That's 5-1-1. Every 5 minutes.
See, like I would need to write that down. Especially going through it, I would need to write it down.
That being said, I'm personally not the hugest fan of the 5-1-1 rule for a couple of reasons. So, number one, in my experience, first-time moms in particular, if they show up at the hospital at that like 60-minute mark of experiencing the 5-1-1, a lot of times it tends to be a little on the early side still. So when I have my own personal clients, what I teach them is 5-1-1 is a great guideline, even 5-1-2, some providers will say for first-time moms, so the whole process for 2 hours. But really what's even more important than the numbers per se are your sensations. So it is so important. One of the number one rules, right, when you're pregnant, when you're in labor, is to listen to your body, to trust your instincts. So it is really not usually relevant to arrive at the hospital unless your contractions are really intense and painful. So if you're able to talk during your contractions, if you're able to pay attention to your Netflix show, if you're able to chat with your partner like during a contraction, even if you've hit the 5-1-1 rule, but you're still kind of like happy and go lucky, it's probably not quite time yet. You're probably still in that early phase of labor, and it would probably be wise to wait a little bit longer. So the contractions have to be intense and painful. Like, let's get real, it's painful for most people. It has to be painful, and they have to be regular. So if they're regular, painful, getting stronger, longer, closer together, and that's been happening for at least an hour or two, then you can go to the hospital. And for some people, that'll be 5-1-1, but for a lot of people, it might even be 3-1-1, 4-1-1, 4-1-2, like this is like a general guideline. So it really your own sensations. Have people arrived at the hospital with 5-1-1 and had their cervix be 1 centimeter open and been sent home? 100% that's happened. Have people also tried to wait to 5-1-1 and delivered in a taxi?
Yeah.
Sure, that's also happened, right? So you need to listen to your body. If you're having contractions every 7 minutes, but you just feel like something's happening, right? Your baby's coming down your pelvis, you can feel it, you feel pressure in your vagina or in your rectum, and you feel pushy, if you're like really sweating or feeling animalistic, like Vanessa was feeling, and you're just, you sense and your body's telling you, you know what, it's time. No partner should be telling, you know, their partners,
5-on-1.
it's not 5-on-1 yet. Like we have to wait. Okay.
Yeah.
It's really should be a sensations thing, sensations based, more importantly than even the exact numbers.
Okay. So that's really good to know because it's good to know. So once at the hospital,
Yeah.
You're put in a room and they put all these kind of monitors on your stomach to measure the heartbeat and all that. And in my experience, the first time when my water broke, I was there for a while because my cervix wasn't dilated enough. So a long time. And then they gave me Pitocin, and I didn't realize how common that was. Like Francesca had got it as well.
Yeah.
So I'm guessing the epidural has a impact on that. Like it's slow. Like once you get the epidural, it'll slow down the labor.
So it can. Again, like we need to break this down a bit because there was a lot of different factors there.
Me.
So first of all, what you experienced, breaking your water before having any amount of significant contractions, is called PROM, or pre-labor rupture of membranes. So when that occurs and contractions don't initiate on their own in the next several hours, then usually what you're looking at is actually an induction type scenario.
Yes.
In order to get your baby to deliver vaginally, ideally within 24, 48, 72 hours if we can. And the reason for that is once the amniotic sac has ruptured and there's a hole or a tear made, then that environment is no longer considered sterile, right? So in theory, any kind of bacteria could ascend vertically through the vagina, infect the amniotic membranes, and it's an infection called chorioamnionitis, which is not great. We don't like it for mom. We don't like it for baby. So that's the idea behind the induction, is providers are trying to avoid that fever and infection scenario. So that's why they would have given you Pitocin most likely.
Okay.
When we're talking about Pitocin in other kind of scenarios, like Francesca was talking about, she was admitted, she got the epidural, and then her labor felt like it slowed and her cervix wasn't progressing very smoothly or rapidly. And so then the next course of action for this particular scenario was the providers offering Pitocin to try to increase the strength and frequency of the contractions.
To get the pregnancy going.
Yes.
To get the labor going.
Pitocin is definitely a very common medication. So Pitocin, for people who don't know, is just like the brand name for oxytocin. So oxytocin is actually a hormone that is naturally produced in our bodies when we're in labor. And it's secreted by our brain and it affects our uterus and our contractions. But there is a form of oxytocin that is produced in the lab called Pitocin. It's given by an IV bag into an IV into your veins to kind of attempt to have the same effect. But what we do know is that synthetic oxytocin, although it works quite similarly to natural oxytocin, doesn't have the added benefit of the natural pain management that occurs with naturally occurring oxytocin. So I'm going to explain that. So when your body is releasing oxytocin when you're in labor naturally or spontaneously, oxytocin actually helps your brain release endorphins, if you've heard of those before. Yes. So those are the morphine-like substances, hormones that act on the different parts of your body to appease pain and to decrease your pain sensations. So when you're in labor, you have that oxytocin, which is causing strong contractions, but you're also at the same time having endorphins being released to help your body be able to cope. With synthetic oxytocin, the way that it acts, it doesn't allow for the same amount of endorphins to be released in that same kind of hormonal dance that occurs more spontaneously. I didn't know that. Which is why most people will say that Pitocin contractions hurt more or feel more intense, is because they don't get that subsequent endorphin release the same way as a naturally released oxytocin.
But will you get the epidural before the Pitocin then? So
it's the epidural is actually a completely different topic than Pitocin or oxytocin. Yes. So they're both, Pitocin and epidurals are just tools that can be used in your labor when they're actually required or necessary. Our epidurals and Pitocin always used super wisely in tertiary care centers in particular. My personal opinion, right, is not always necessarily. So they're useful tools that should be used wisely. Because like any medical intervention, right, medical interventions are used when the expected benefit outweighs the expected risks. And we're not always fantastic at doing that with low-risk pregnancies. So the epidural, to answer your question, the epidural is a tool. Okay, so it's neither good nor bad. It's just this tool that's available to help women cope with their pain if they feel like the natural or the non-pharmacological techniques for pain management are not sufficing for them. So first and foremost, within that sentence in and of itself, the first problem is that most people don't get any information about the non-pharmacological pain management options. So different movement, hydrotherapy, right, shower, tub, pressure points, acupressure, rebozo, like there's a million different things. People don't learn anything about that. So they feel like their only option is the epidural, or they're told by all their friends, like, just get the epidural, right? You need the epidural. So the epidural is a tool. When used appropriately, when initiated, when you are already in active labor. So this is the idea kind of behind showing up at the hospital when you're already having strong regular contractions, which is what Vanessa did, right? So kudos to her. That's amazing that she got to the hospital and she was that far in her process. The idea is at that point, if you are admitted to the hospital and decide to get the epidural or need medical interventions, it's much less likely to slow your labor or to cause issues like that, unfortunate side effects like that. So when epidurals are taken very early in labor, sometimes it can slow the labor process a little bit when the contractions were not already very well established on their own, right? That train was not rolling uncontrollably at that point. Sometimes the epidural via various mechanisms can slow things down, but not always. And epidurals have not actually been linked to a higher risk of C-section. People tend to think that. But they are linked to slightly higher risk of forceps or vacuum delivery.
Really?
Yeah, because of the blunting of the sensations. And sometimes it can make pushing a little bit trickier when you feel very frozen.
Yes, that's true.
Yeah. I'm not sure if that even answered your question. I feel like there's so many topics that I want to go
I know.
and give info on.
Okay, so then let's say one chooses to get the epidural, or in our case, I think the three of us got the epidural.
Most women do.
Yeah.
Like, to be perfectly clear, right? Like, I'm not even sure what we're at right now with epidural rates in Canada, but it's quite high, right? In particular, my area of practice is Montreal, right? With the center where I worked, we had a rate of epidurals that was upwards of 80 or maybe even 90%.
Yeah.
Right? Most people do take it because it is realistically the most effective in terms of diminishing pain sensations. Of course, it's the most effective.
Right. And then the contractions will get closer together
over time. Hopefully, if you're in spontaneous labor. Yeah.
And then all of a sudden, like, especially in Alex's case, for her third, it was like, lift your leg up, it's coming out. So obviously
that's called a precipitous birth.
Okay. Yeah. So for the first, that rarely happens, I would assume.
It's rare. It could happen, right? Listen to your body, but it's not so common. It is definitely more common when you have 2, 3, or more babies.
And then, but in Vanessa's case, I just want to talk about that a little bit because that was very different.
Yeah.
She, like you said, waited, her cervix was dilated. She got to the hospital, she got the epidural. So she kind of did everything she was supposed to do, like by the book.
Yeah.
And then all of a sudden it was like surprise emergency C-section.
Yeah.
So I just want to touch on that a little bit because it wasn't like a regular vaginal birth like Francesca and myself.
Well, Francesca had a C-section too.
Oh, she did have a C-section. You're right. Sorry.
Yeah. But hers was, so Vanessa had a C-section for what we call fetal distress.
Okay.
And Francesca had a C-section for what we call failure to progress, or the medical term is labor dystocia.
Okay.
So either an arrest or a significant slowing of the cervical dilation or the fetal descent in the pelvis.
So in Francesca's case, the labor was just not progressing fast enough, basically.
Yes. And what does that even mean, right? Fast enough. But basically she was there for many days. And it sounds like at some point the cervix was just no longer dilating.
And that's possible.
It is possible. That was my understanding.
Okay.
It is definitely possible. When I was personally listening back on her story, I definitely think that, the context in which she gave birth, the whole COVID situation, not having a partner, having the healthcare professionals really go see her very infrequently, was really unfortunate. And may have possibly contributed to the fact that her labor progressed a little bit slowly, because it doesn't sound like she necessarily had amazing support in those factors that contribute, like that can help a labor progress fast. So things like oxytocin, right? Oxytocin is the love hormone. So having a partner
Yeah.
it's not only for fun and for that emotional support, it actually helps labor progress.
Okay.
To be accompanied by somebody who loves you and can make you feel safe and comfortable. So that was definitely like kind of a harmful factor in her case. It sounded like, based on what she was saying, that she was given the epidural and then she kind of was like stuck in the bed, right? And she didn't get to move around a whole lot, and the nurses didn't come see her very much. So it doesn't sound like she had the option to move her body very much, use gravity to try to assist her baby to come down her pelvis. She also said that, she didn't eat anything for a long, long time. So definitely being in a state of a bit of starvation, right? Or I think she said she had like one snack pack or like one Jello. Her whole hospitalization. That's not really evidence-based or helpful. Your uterus is a muscle, right? It needs fuel to function just like any other muscle. So I think there was probably, and this is just again, right? Like, no, I was not there. I can't really comment.
Sounds like,
But her experience is the COVID thing was definitely special, but it is something that happens sometimes in hospitals where you'll get a failure to progress situation. And sometimes I look back on those situations and I wonder, like, what if she had her partner? What if she was allowed to eat? What if she was able to reposition her body? Could outcomes have been different? Maybe yes, maybe no. And there's not like a whole lot of point in Francesca, looking back and asking those questions because, it's happened and it's not meant to make anybody feel guilty.
Of course.
But it's just, if you have future babies and your experience when you picture it or when you think about it, to get information about those kinds of things like eating and drinking in labor, different positioning tools, how to get your labor to progress nicely, oxytocin, pain management options, they're actually really useful, right, in trying to reduce those situations where we're told that our labor has slowed.
It's funny that you say that because for her second, she got a planned C-section.
Yeah.
But she could have given birth vaginally.
Perhaps.
Offered that.
Yeah, I think she was offered a VBAC, right?
Yeah.
So she could have had the option to attempt a trial of labor.
So it doesn't mean that if you had a C-section the first time, you have to have a C-section the second time?
Not necessarily.
Okay.
So for the most part, we know that statistically, more women than not are candidates for what we call a VBAC or a TOLAC, so a trial of labor after cesarean. But you do need to meet certain medical criteria. So I would encourage people to ask their own providers, obviously. It's things like the spacing of your pregnancies. So typically, they'll encourage you to have your babies minimum like 18 months apart. 24 months or more is even better. They'll do, like Vanessa was mentioning, ultrasounds to check the thickness of your uterine scar, which is the limiting factor. Usually, if the scar is too thin, it can be a problem in terms of planning a VBAC. The size of your baby. What was the situation with your first pregnancy? Why did you have a C-section the first time? And so depending on those factors, yes, for the most part, if you have a low-risk pregnancy, a VBAC is an option that's offered to you by your provider. And then you get to weigh the pros and cons of both options, so the VBAC or the planned C-section, and you decide what's right for you.
Thank you. And coming back to Vanessa now, so like we said, she kind of did everything that she was supposed to do, and then all of a sudden, out of nowhere, she explained that there's like 50 doctors that came in, and it was like, emergency C-section. And that, I think, really, as she was telling the story, kind of struck a lot of emotion because it was very sudden and shocking and not part of her plan. And so I guess, she had to go through it because that's what was recommended by the doctor. And then the skin to skin, she once Emma was born, Chris had to take her right away. So I want to touch on like emergency C-sections. Like first of all, I don't really remember what was her case, like why she had to have the emergency C-section. I know there's a million different reasons in various women, but in her case exactly. And I don't think that I've never had a C-section or an emergency C-section, so I don't know that doctors really have the time to sit you down and offer you. So let's explain that emergency C-section procedure a little bit.
So emergency C-sections are typically C-sections that occur when you're already in labor for the most part. They can sometimes happen following like a routine ultrasound or prenatal appointment, but typically you are in labor or you're experiencing an induction. And at some point in time throughout the process, there is a medical indication or a reason pops up for which the baby's birth needs to be expedited. Okay. So for the most part, typically you're talking about fetal distress scenario, meaning that For whatever reason, when we're monitoring the baby's heart rate, we notice that the baby is showing signs of not tolerating the labor. Okay, and that could be for a bunch of different reasons. I know she was saying that she was also on Pitocin, I believe. Sometimes that is a potential side effect of Pitocin. It's not that common, but it can happen where if contractions are very strong or very close together, or if our baby's on the smaller side or is compromised in any way, the act of having contractions, which in and of itself decreases the blood flow through the placenta temporarily in a physiologic way, will stress the baby. And what we don't want, obviously, is for the baby to become so stressed that the baby's going to be deprived of any kind of oxygen or risk coming out, with any kind of distress, right? Respiratory or otherwise. So in her case, it sounded like she was laboring at home. Things were going well. She showed up at the hospital. She got an epidural. For some reason, her labor slowed. Maybe it was the epidural. Maybe it was something else. Maybe her baby was in a not optimal position in her pelvis where things slowed. I'm not too sure. At some point, Pitocin was suggested because things were moving slowly. And then it sounds like her baby was not tolerating either the Pitocin, the contractions themselves, or something else. And then the doctors noticed on the monitor or by listening, if they were using a daptone at that point, I'm not sure what kind of monitoring she had, they noticed that the heart rate was dropping in some kind of way. And fetal heart rates can drop during labor. It's quite common. But what we don't like is when there's a repeated pattern of the fetal heart rate dropping, or when there's one significant drop, which sounds like was probably what occurred. Where on the monitor, the baby's heart rate goes down, 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 and is not recovering fantastically. And therefore, the provider said, we need to get the baby out, right? There's no time to wait until your cervix is 10 centimeters, go through the pushing phase. The baby needs to come out now, right? So therefore, she was wheeled into the emergency C-section. But that's definitely a scary experience because, like you said, things happen very fast, right? If you're in a tertiary care center, sometimes from the moment that a provider says the word C-section, the baby can be out 5 minutes later. And it's the whole what just happened type of scenario. So typically, emergency C-sections are related to fetal distress. The baby's not doing well, and there's not a whole lot of time to talk about it. Hopefully, providers still, as we're walking towards the operating room, will try to explain quickly to the parents, right? Okay, this is the situation. This is why we believe you require a C-section. They'll consent you to the surgery, right? So this is what a C-section is. These are the risks implicated. Do you agree to receive a blood transfusion if you need one? Blah, blah, blah. Sign the paper, and then you get to the operating room, and the baby's born soon after.
And in both cases, when Tessa and Emma were born, like I said, they both experienced kind of like convulsions, and then Francesca was sick and had to remove Tessa, and then Emma had to go on Chris. So was that because they lost too much blood? Is that what they...
So not necessarily. First of all, I want to say I'm really glad that they were both offered the opportunity to do skin to skin with their babies in the operating room. Unfortunately, not all hospitals do that, but it's becoming more and more common. And it is 100% something that you can request or put on a birth plan, for example, if you're making one. Or to discuss with your provider ahead of time. If I do need a C-section, I really care about having the opportunity to do skin to skin with my baby. So kudos to those hospitals. And the shaking during a C-section or after giving birth can actually happen not just with C-sections, but with vaginal births too. So there's a lot of different hypotheses to the mechanisms behind why some people will shake really uncontrollably or feel like they're convulsing. So first of all, when we're talking about vaginal births, there's a huge hormonal shift that occurs once your baby's out and once your placenta is expelled. And so that kind of big drop in hormones can sometimes cause shaking. If you've lost a significant amount of blood, it can cause shaking. Your blood pressure goes down, it can cause shaking. If you receive any kind of medications to control your bleeding, sometimes that can cause shaking or fever. Just like the shock to the system, to the body, right, of expelling the pregnancy can make some people shake. In the case of a C-section, the anesthesia itself, so either the epidural if they use that or the spinal anesthesia if they use that, the medications in there can cause shaking. And then it's also very cold in an operating room. It's really cold. That can make you shake as well. There's fear, right? There's 100 different reasons why you can shake. It's not dangerous usually. It just can feel a little bit unsettling to feel like you can't control what's going on with your body. And depending on what the mechanism of the shaking is, oftentimes providers can give you certain medications to decrease the shaking, and things as simple as like a warm blanket being placed over you in the operating room or in the birthing room can help too.
Yeah.
So there's a lot of different factors, but it is quite common and it's not something that's really talked about too much. And when people get to their birth and they shake, that can be distressing
Scary,
for them. It can be
for
scary,
sure.
like what is happening.
Right.
So to be clear, it's not convulsions. It's not
Okay.
anything that's neurologically based. It really is more of a physiological thing in terms of bleeding or blood pressure or hormonal shifts or temperature in the room, and just that adrenaline boost that a lot of people get when they give birth.
I want to ask you one thing for Vanessa, and I just feel like when she told us her labor experience and how she, really touched on, I did everything right, and then I was robbed of the vaginal birth in a way, And then on another podcast, Bringing Baby Home, she talks about, and she still gets very emotional about how she, didn't have that connection with Emma at the very beginning.
Yeah.
So, and I've spoken to her about this already, and I just wanted to get your opinion. Do you think that there's a connection between her labor, how she gave birth to Emma, and then the kind of lack of connection she felt with her afterwards?
There can definitely be a connection. And when we were talking about, Francesca's experience with a C-section and Vanessa's experience with a C-section, she actually used those words, right? She said it was traumatic for me.
Yeah.
It was an emergency and it was traumatic.
Yeah.
So people who perceive their birth experience as traumatic, and a trauma is what the person says it is, right? So again, like we were looking at Francesca thinking that was traumatic. She didn't feel that it was traumatic.
Correct.
So people who look back on their experience, no matter if it was vaginal or C-section or an emergency or not an emergency, if people felt that they were in danger, that their baby was in danger, that they weren't respected, that something went wrong, that they were traumatized, 100% it can affect the whole postpartum experience, right? Whether you got to be with your baby immediately, whether you were separated, it can cause a lot of psychological repercussions to experience a trauma or a traumatic birth like that. So it could definitely be something that contributed to her feeling like it took some time to build that bond with her baby. Some people have like even out of body type of experiences or disconnected from their bodies if they have to give birth surgically, particularly if it wasn't their plan, right?
Correct.
They weren't thinking about having a C-section.
Yeah.
Feeling like something was done to our body that we weren't expecting. It can definitely be
because the
kind
second time around it was planned, the C-section with Alice, and she didn't have any problems connecting with her, bonding with her, and so
well, if she didn't perceive her birth as traumatic, right, then there's sometimes not as much of a disconnect, right, or like a little psychological break in that experience. And again, all sorts of emotions can come from having a C-section that's unplanned.
Right.
Some people can feel very grateful about that experience, right, and feel lucky that they had that medical management. But a lot of people can feel disappointment, anger. Some people even feel a bit of resentment towards their babies, right? Like, why did you have to have that heart rate problem, right? Like, now I had to be cut open and now I have this longer recovery. This is not what I pictured, right? Like, why did you have to be naughty? Some people have those thoughts and there's nothing wrong, right? It's a normal human reaction.
Right.
So I would just encourage people, if they've had an emergency C-section or any kind of birth really where they're looking back and they don't feel great about it, they have questions or they feel upset in any kind of way, to talk about it, because it happens more frequently than people think. And it's just never great, right? To fester those emotions, particularly in the postpartum period when there's so many changes and so much going on, to talk to their obstetrical care provider and say, like, I would like to kind of process what happened. Can we go over again? Like, why did I need a C-section? Like, what exactly was wrong with my baby's heart rate? To be clear, there was no other alternative. I couldn't have done anything different. Right. And to kind of go through the process or talk to somebody who's knowledgeable about birth to debrief about a birth experience can be very helpful and healing in certain situations.
Yeah, because she did say, I remember, before giving birth and coming to the hospital, it would have been nice to have the doctor or someone say, a C-section, and that's with every pregnancy, maybe, like a C-section may be required. Here are the risks, blah, 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 but that doesn't happen because it's not something I think that's offered willy-nilly.
Yeah.
So,
and also I really truly think it's also like a time constraint thing. Once again, with our system, right, your OB appointments are so short, they're 5 minutes. There's not a whole lot of time, which is why I encourage everybody to take prenatal classes. Generally, C-sections will be addressed, even if it's, in an abridged kind of way. When I take clients, in my classes, my prenatal classes, I always offer information about C-sections because you never know. It could technically be an option.
Yeah.
I don't belabor the point and make it seem like that's the plan, but it's a disservice to people to not explain
Exactly.
what is a C-section like? Like, what is the chain of events?
Mm-hmm.
What are your options?
Yes.
People don't realize, right, that they have the option to do skin to skin in certain situations, ask for music to be played. Would they like to see the birth? Could the drape be lowered? Could a partner film the birth? All those kinds of things that they don't realize are necessarily options and can make their experience sometimes more positive.
Mm-hmm.
To just think those things through a little bit before can be really helpful in that eventuality where you require a C-section.
Yeah. And I think that's really important. And I just want to finish on this, that, you know, a lot of, at least me, and I think I can say for my friends, when we're ready to go into labor and to give birth, we just think, you know, it's going to be 1 or 2 days. And it's going to go and we're going to give birth and the medical professionals will deal with it and bada bing, bada boom,
Mm-hmm.
whether it's a C-section, whether it's vaginally, like it has to be done. And we'll just
Mm-hmm.
listen to the medical professionals and that'll be that. But in retrospect now, I think what I think is important to say is that a lot of things that happen during labor, like we've seen with Vanessa or even myself, can have repercussions emotionally in the future in postpartum. And so your labor is an important, you know, I wouldn't like thing to plan, I think.
Maybe. It's an event in your life.
Yeah.
Right? I always talk to my clients, and when people ask me what I do, right, and I say, okay, well, when you had a wedding, when you got married, right, it was this event in your life that you're going to remember for your whole life. So what do people do? They plan. They spend hours and hours planning. They get a wedding planner and they think about their options, right? Because they want the day to be the way that they hope and go smoothly, right? And have happy memories.
What are the risks? Is it going to rain? Should I have a tent? You know, so that it's exactly the same.
And then when people want to give birth, right, then they say exactly what Francesca said. You know, my birth plan was whatever the doctors say, I'm going to do it. And to be clear, right, 99.999% of the time when medical practitioners are making recommendations or suggestions, it's in your best interest, of course. But that being said, in our system where things are so expeditive and there's not a lot of time to go into detail about your options, it's very, very wise to inform yourself ahead of time so that you're responsible for your own birth experience in the sense of, you know, if, to be clear, okay, scrap that part, Arnie. I don't want it to sound like I'm telling people that they're responsible for what happened to them, but more, it's when you give birth, it's your experience, right? It's not the doctor's, it's yours. You're the one who's going to remember it forever and tell your birth stories to your friends and live with the repercussions, right? Whether positive or negative of that experience. So I think it's worth investing some time in just learning about the process, what your options are, and how, no matter what the scenario is, to make sure that you optimize the scenario, right? So if you do need a C-section, what can you do to make that more joyous or less stressful, right? Yeah. As opposed to just kind of ignoring it and just, you know, thinking about, you know, well, the doctors will take care of it and it'll be fine.
Exactly.
Sometimes it's not fine, right? So it can actually be an intervention to decrease birth trauma, to do things like take prenatal classes, consider hiring a doula as a support person.
Absolutely.
And being informed to try to have a positive birth experience, no matter what the scenario ends up being.
Completely agree. Thank you so much, Tanya. I really appreciate it.
It was my pleasure.
I'm so happy we talked about that. I think it's a really important.
My favorite topic.
Awesome. Thank you.